Abortion is one of the few issues where public messaging, private experience, and political strategy collide so sharply that even people who agree on the right to choose can feel internally split. Pro-choice advocacy has spent decades refining a framework that protects autonomy, reduces stigma, and encourages early, medically informed decision-making. That framework works, but it also creates a subtle psychological tension. When the public narrative becomes streamlined for access and destigmatization, it can drift away from the lived emotional and moral complexity many people encounter when facing the decision themselves. This examines that tension. It traces how pro-choice messaging balances urgency with empathy, how stigma reduction shapes the information people receive, and why cognitive dissonance can emerge even among those who fully support reproductive autonomy. By unpacking the layers of framing, emotion, and epistemic access, we can better understand not only the political landscape but the human experience at its center. Cognitive dissonance inside pro-choice messaging. How framing, stigma avoidance, and decisional speed interact. The pro-choice framework rests on a few widely shared commitments. Abortion is the pregnant person's choice. Abortion should ideally occur as early as possible. Abortion should be as rare as possible. Not because they're immoral, but because preventing unwanted pregnancy is better for everyone. Access must remain unobstructed, especially early in pregnancy. To achieve these goals, pro-choice advocates have spent decades reducing stigma and folding abortion into the category of healthcare. This is strategically effective. It lowers fear, reduces shame, and helps people make decisions quickly enough to avoid later-term procedures. But this strategy has a side effect. When the public framing becomes too light, too clinical, or too routine, it can create cognitive dissonance once the person confronts the actual emotional and moral weight of the decision. Let's break that down. 1. The two layers of abortion experience. Public framing versus private meaning. Public framing. It's healthcare. It's a routine procedure. It's your choice. Trust yourself. Don't overthink it. Earlier is better. Private meaning. For many people, this is a major life decision. I'm ending a potential future. I want to be sure I'm not making a mistake. I feel something about this, even if I support the right. The gap between these two layers is where cognitive dissonance emerges. If the public framing is too light, the private meaning can feel heavier by contrast. If the public framing is too heavy, people may delay, which increases medical risk and moral conflict. So pro-choice messaging walks a tightrope. 2. Why pro-choice messaging leans toward lightness. The strategic logic. Pro-choice advocates worry about two things. If people second-guess too long, they may end up needing later-term abortions, which are medically more complex and emotionally more charged. If stigma is high, people may avoid clinics, hide pregnancies, or feel morally paralyzed. So the messaging aims to reduce hesitation, normalize the decision, encourage early action, prevent shame-driven delay, keep the choice psychologically accessible. This is not deception, it's strategy, but a strategy which has trade-offs. 3. The trade-off. Cognitive dissonance and polarization. How the messaging gap widens the pro-life, pro-choice divide. Because pro-choice messaging emphasizes healthcare, autonomy, decisional speed, destigmatization, while pro-life messaging emphasizes moral gravity, fetal value, existential stakes. The two sides end up talking past each other. Pro-lifers see the pro-choice framing as trivializing something profound. Pro-choicers see the pro-life framing as moralizing something deeply personal. This creates a perception gap. Pro-lifers think pro-choicers are taking abortion lightly. Pro-choicers think pro-lifers are inflating the moral stakes to control women. Both sides misread the other, because the public messaging of each side doesn't match the private reasoning of many individuals. 4. What could bridge the divide? A more robust, honest articulation of the frameworks. There's value in making the underlying moral frameworks explicit, without giving either side disproportionate leverage. That means acknowledging that abortion can be emotionally complex even when morally permissible, affirming that bodily autonomy remains the decisive factor, recognizing that destigmatization is necessary, but shouldn't erase the seriousness of the choice, allowing room for people to feel conflicted without being shamed, clarifying that healthcare framing is a tool for access, not a denial of moral nuance. This kind of clarity doesn't weaken the pro-choice position, it strengthens it by making it more psychologically realistic and less dependent on strategic euphemism. 5. Why early medical involvement matters. Destigmatization isn't just cultural, it's epistemic. A crucial piece of the puzzle is how individuals actually become informed. Not informed by ideology, not by advocacy groups with strategic goals, but by medical professionals who can contextualize the pregnancy, the risks, and the options in a way that respects the private, interior nature of the decision. Here's the key point. Stigma delays contact with medical professionals, and delayed contact increases the influence of non-medical actors, whose goals may not align with the pregnant person's well-being. When stigma is high, people hide their pregnancies, they avoid clinics, they seek information from peers, online forums, or ideologically motivated groups. They enter the decision process later, more stressed, and less informed. They become vulnerable to messaging that doesn't track their personal circumstances. When stigma is low, people seek medical consultation early. They receive individualized, medically grounded information. They learn about gestational timelines, risks, and alternatives. They gain tools for reflective, autonomous decision-making. They avoid being funneled into someone else's agenda. This is not merely a practical benefit, it's a moral one. It ensures that the person making the decision is the one who bears the risk, the consequences, and the lived experience. 6. The epistemic asymmetry. Why medical information is different. Not all information is equal. Advocacy groups, on either side, tend to have objectives, narratives, preferred outcomes, selective framings. Medical professionals, by contrast, are trained to Assess the specific medical context. Explain risks without moralizing. Provide options without coercion. Respect patient autonomy. Tailor information to the individual's health, history, and circumstances. This matters because abortion is not a generic moral question, it is a situated one. The meaning of the decision depends on gestational age, medical risks, psychological state, social supports, future plans, personal values, prior pregnancies, trauma history, health conditions. Only a clinician can integrate these variables into a coherent picture. So the argument becomes, destigmatization is necessary not because abortion should be trivialized, but because stigma blocks access to the very information that makes the decision morally and medically grounded. 7. How this completes the cognitive dissonance model. The loop closes. 1. Pro-choice messaging reduces stigma. 2. Reduced stigma enables early medical consultation. 3. Early medical consultation provides individualized, non-ideological information. 4. This supports swift, autonomous, well-informed decision-making. 5. Swift decisions reduce the need for later-term procedures. 6. This aligns with both medical best practice and pro-choice goals. 7. But the public messaging can create cognitive dissonance if it oversimplifies the emotional weight of the decision. This framework explains why destigmatization is ethically important, why medical involvement is epistemically superior to ideological involvement, why pro-choice messaging looks the way it does, why cognitive dissonance can still arise, how to bridge the gap between public framing and private experience. 8. The information problem. What kind of information actually changes a decision? And what does that tell us about rational choice? Raising a subtle but crucial question. Is there a specific piece of information that, if known, would cause a pregnant person to choose differently, and if so, does that mean the earlier decision was less informed? This is the heart of the epistemic challenge. Not all information is equal, not all information is relevant, and not all information is rationally weighted. To understand this, we need to distinguish 3 categories: a medically relevant information, information that changes the actual risk profile, gestational age, medical complications, viability, genetic anomalies, maternal health risks, medication interactions, future fertility implications. This is the kind of information that should change decisions, because it changes the underlying facts of the situation. This is why early medical consultation is ethically central. It ensures that the decision tracks the real state of the world, not an imagined or emotionally distorted one. The emotionally salient information, information that feels morally heavy, but may not change the underlying facts. Ultrasound images, fetal heartbeat audio, graphic descriptions, symbolic language, baby, child, life, emotionally charged narratives. These can dramatically alter decisions, not because they change the medical reality, but because they change the psychological salience of certain features. Humans overweight emotionally vivid information, even when it has little rational bearing on the decision. This is the same cognitive bias that makes people run into burning buildings to save someone with a 0.001% chance of survival, donate more to a single identifiable victim than to thousands of anonymous ones, fear flying more than driving despite the statistics. Emotionally vivid cues hijack our decision-making architecture. See ideologically framed information, information filtered through a goal, pro-life crisis pregnancy centers, pro-choice advocacy messaging, religious framing, political framing, moralized narratives. This information is often structured to produce a particular outcome, not to illuminate the actual decision space. The pregnant person should be informed by medical professionals, not by actors with strategic objectives. Medical professionals are not neutral in the sense of being value-free, but they are neutral in the sense of being non-agenda-driven. Their role is to provide risk assessment, medical facts, procedural options, timelines, safety considerations, not moral pressure. 9. The rationality problem. How should a person weigh different kinds of information? A deep issue in decision theory. People often respond disproportionately to emotionally heavy information, even when it is statistically irrelevant. This is not irrational in the sense of being stupid. It's irrational in the sense of being misaligned with the person's own long-term values. For example, a person who would normally avoid a 1% chance of severe harm might suddenly accept a 10% chance because the situation feels heroic. A person who would normally prioritize bodily autonomy might suddenly reverse course after hearing a heartbeat, even though the heartbeat doesn't change the medical facts. A person who would normally avoid late-term procedures might delay because they feel overwhelmed by stigma or shame. This is why the timing and framing of information matters. If emotionally charged information is introduced before medically relevant information, it can distort the decision. If medically relevant information is introduced early, it anchors the decision in reality rather than in emotional reactivity. 10. Why destigmatization is epistemically necessary. Stigma doesn't just affect feelings, it affects the entire information ecosystem. Stigma delays, clinic visits, medical consultation, ultrasound timing, risk assessment, access to medication abortion, conversations with professionals who can contextualize the decision, and delay increases the influence of ideological actors, emotionally manipulative tactics, misinformation, fear-based narratives. So the argument becomes, destigmatization is not about trivializing abortion. It is about ensuring that the first information a pregnant person receives is medically grounded, not emotionally manipulative. This is the epistemic core of the pro-choice argument. 1. Abortion decisions are morally and emotionally complex. 2. People overweight emotionally vivid information, which can distort rational decision-making. 3. Medical information that reliably tracks the actual decision space. 4. Stigma delays access to medical information, increasing vulnerability to ideological influence. 5. Destigmatization ensures early medical consultation, which anchors the decision in reality. 6. Early anchoring prevents late-term procedures, which aligns with both medical best practice and pro-choice goals. 7. Therefore, destigmatization is not moral trivialization, it is epistemic protection. The debate around abortion is often framed as a clash of moral absolutes, but the reality is far more intricate. When we look closely, the core challenge isn't simply disagreement between pro-choice and pro-life worldviews. It's the internal friction created when strategic messaging, emotional experience, and medical realities intersect. Destigmatization remains essential, not because abortion should be treated lightly, but because stigma distorts the very information people need to make grounded, autonomous choices. A more honest, psychologically realistic approach doesn't weaken the pro-choice position, it strengthens it. It acknowledges complexity without weaponizing it, affirms autonomy without trivializing the decision, and centers medical knowledge over ideological pressure. By recognizing how cognitive dissonance arises, and why, advocates can build a framework that is both ethically coherent and emotionally sustainable. In doing so, we move closer to a discourse that respects the full depth of the decision, and the people who must make it. The decision-making process is supported by concrete tools developed by medical and public health organizations. These are not abortion decision resources, but maternal-relevant material. Clinics routinely provide structured decision aids such as the IPA's Abortion Decision-Making Toolkit, the Bedsider Pregnancy Options Workbook, the National Abortion Federation's Patient Decision Guide, and the WHO Self-Managed Abortion Decision Aid. These materials function like a decision tree. They begin with medical anchors, gestational age, available methods, health risks, then move through values clarification prompts, branching questions about future plans, and worksheets that help the pregnant person articulate what matters most to them. These aren't ideological pamphlets, they're evidence-based tools designed to help people map the decision space clearly, integrate emotions without being overwhelmed by them, and ground their choice in medically relevant information rather than in fear, stigma, or external pressure. By making the structure of the decision explicit, these aids operationalize autonomy. They give the person a stable cognitive framework for navigating a morally complex moment under real-world time constraints. The information divide, medical decision aids versus PRC disinformation. A crucial part of the decision-making landscape is the stark difference between medically grounded decision tools and the materials distributed by pregnancy resource centers (PRCs). While clinics and public health organizations provide evidence-based aid, PRCs distribute a very different kind of information. Their pamphlets, counseling scripts, and options booklets are often designed not to clarify the decision space, but to steer the pregnant person toward a predetermined outcome, continuing the pregnancy. PRCs typically present themselves as medical or counseling centers, but most are not licensed medical facilities, and many do not employ clinicians. Their materials frequently include medically inaccurate claims, such as overstating the risks of abortion, misrepresenting fetal development, or promoting scientifically unsupported concepts like abortion pill reversal. The framing is intentionally moralized and emotionally charged. Ultrasounds are used as persuasive tools, language shifts from pregnancy to baby, and pamphlets emphasize guilt, regret, or spiritual consequences. This is not information, it is persuasion wrapped in the aesthetics of care. By contrast, medical decision aids are structured to support autonomous reasoning. They begin with factual anchors, gestational age, available procedures, medical risks, and then guide the person through values clarification exercises, branching questions, and scenario planning. These tools help the pregnant person articulate what matters most to them, map out the consequences of each option, and integrate emotional responses without being overwhelmed by them. They are designed to illuminate the decision space, not to narrow it. The contrast in framing is profound. Medical tools aim to reduce cognitive load. PRC materials aim to increase emotional salience. Medical tools treat the pregnant person as a decision-maker. PRCs treat them as someone to be influenced. Medical tools support autonomy. PRCs attempt to redirect it. This divergence is not merely ideological. It is epistemic. It determines whether the first information a pregnant person encounters clarifies their options or distorts them. This is why destigmatization and early clinical contact matter so deeply. When people reach medical providers first, they receive structured, accurate, non-coercive decision aids that help them build a coherent internal decision tree. When they encounter PRCs first, the decision tree becomes skewed by misinformation, emotional manipulation, and moral pressure. The difference between these two information ecosystems is not subtle, it shapes the entire trajectory of the decision. 1. IPA's Abortion Decision-Making Toolkit, a structured set of worksheets and decision aids used globally in clinics to help patients think through options, values, and medical considerations. 2. Bedsider Pregnancy Options Workbook, a patient-facing workbook with branching questions, values clarification exercises, and scenario planning. 3. National Abortion Federation, NAF, Patient Decision Guide, a medically grounded pamphlet used in many U.S. clinics to help patients understand procedures, timelines, and decision factors. 4. World Health Organization Self-Managed Abortion Decision Aid, a WHO-endorsed tool that helps people evaluate safety, timing, and medical eligibility for medication abortion. 5. UCSFA NSIRH Pregnancy Options Counseling Guide, a clinician-oriented guide that includes decision tree logic, values clarification, and structured counseling prompts. 6. Planned Parenthood Pregnancy Options Counseling Materials, includes worksheets, informational pamphlets, and structured questions used in counseling sessions. 7. Ottawa Hospital Research Institute, Ottawa Personal Decision Guide, OPDG, not abortion-specific, but widely used in reproductive health settings. a validated decision aid framework for complex medical choices.